what I'm going to discuss in the next half an hour is two important areas of practice for clinicians. One is polycystic ovarian syndrome and ovarian abnormalities, and the second one is hirsutism. Actually, there is a lot of clinical medicine involved in that. I'm not going to go too deep into that. Provide a little bit of perspective on what these disorders are, what is exactly called PCOD, a bit about investigations, and then of course we could have discussions again in the time provided. Basically, what really is polycystic ovarian syndrome? Polycystic ovarian syndrome or polycystic ovaries were first described by Stein and Leventhal, which we read in our gynec textbooks when we were students, and that was actually a pathological entity based on findings of large multiple follicles and a central thick stroma on ovaries of women who have had long histories of amenorrhea or oligomenorrhea. And now, of course, he labeled them as polycystic ovaries and said that sometimes women with irregular periods have this kind of a problem. Now, of course, it has moved on and it is now recognized as a complex metabolic problem. It's not really a gynec problem, really speaking. It's a metabolic medical problem which is characterized by three important things. One, cutaneous hyperandrogenism. So there is some form of hyperandrogenism, either alopecia, skin, hair, acne, something, or menstrual irregularity, some form of menstrual irregularity indicating ovarian dysfunction, and maybe polycystic appearance of ovaries on ultrasound. Now, somehow this whole syndrome has become synonymous with finding polycystic ovaries on ultrasound. It is not so at all. As we move ahead, I'll show you. But apart from that, there are also multiple other factors which includes obesity and insulin resistance, and which includes a lot of other genetic and environmental factors. So it's not just polycystic ovaries, but it's a whole conundrum of problems coming together. The various definitions now say that to diagnose PCOS, we must have two of these three things: some evidence of chronic anovulation, evidence of hyperandrogenism, either clinical or biochemical, both are fine, and absence of any specific cause of hyperandrogenism, like androgen producing tumors or congenital adrenal virilizing hyperplasia. So if there is no specific cause for hirsutism or androgenism, and if the woman has anovulatory cycles, this is polycystic ovarian syndrome till otherwise proven. As you can see here, there is nothing mentioned about ultrasonography at all. So what I was saying was that PCOS has actually moved on to be a clinical diagnosis based on a combination of two of these things. Some other criteria will include polycystic ovaries there, but again, there are lots of caveats and what really polycystic ovaries really mean. And these are the consensus guidelines published last year in December from the Endocrine Society, and they say clearly, we suggest that the diagnosis of PCOS in an adolescent girl be made on the presence of clinical and or biochemical evidence of hyperandrogenism after exclusion of other pathologies in the presence of persistent oligomenorrhea. Very simple. Oligomenorrhea plus hirsutism is PCOD if you rule out other disorders. And just the presence of polycystic ovaries on ultrasound, especially in adolescent girls, is insufficient to make a diagnosis of PCOD in adolescent girls, because this can be a normal phenomenon in these individuals. So people who harp on this ultrasound showing polycystic ovaries, it is of no consequence. That's important. Now, when we say that we must rule out all these other disorders, what other disorders are we talking about? These disorders include significant thyroid disease, significant hyperprolactinemia, and things which could cause hyperandrogenism, like non-classic congenital adrenal hyperplasia, typically the 21-hydroxylase deficiency producing high androgen levels, and of course virilizing tumors of adrenals or ovary, which are extremely uncommon. So primarily we say that if a girl has been ruled out to have thyroid disease, hyperprolactinemia, and CAH. And if she has some hirsutism and some ovulatory dysfunction, she has PCOS. Whether her ovaries are normal or large or enlarged or bulky or whatever, it doesn't really matter. That's what it really means. Now, this is a big slide, but what I was trying to show was that when we say that these women who have ovulatory dysfunction have PCOS, they could at the same time have a variety of other disorders. This could include pregnancy. Please do not forget that, because pregnancy is one of the commonest causes of amenorrhea. They could have hypothalamic amenorrhea. They could have primary ovarian insufficiency. They could have androgen secreting tumors. They could have Cushing syndrome, and they could have acromegaly. So all of these are going to present in the same way, that is ovulatory dysfunction and some form of hirsutism. So you may have to actually rule out these disorders. The reason for projecting this slide is not to show you all this. It's not important. The reason to show you this is because I wanted you to remember these 5 or 6 things. Because when we say investigations for PCOS, we are in fact doing these investigations to rule out these disorders. As we'll come to that a little later, because there are no specific investigations for polycystic ovarian syndrome. The investigations are done really to rule out all these, so that if you have ruled out all these, you can say, okay, by exclusion, this is now polycystic ovarian syndrome. That's the whole idea. When we say ovulatory dysfunction, the first one, of course, as I said, is menstrual irregularities. This means either amenorrhea of long duration or infrequent menstruation, that means oligomenorrhea. It could be normal cycles also, but infrequent or absent ovulation. Not all regular cycles are ovulatory. So you can have anovulation in the presence of normal cycles as well. And of course, it has to have a peripubertal onset. You cannot expect PCOS to start at the age of 30 or 35 or 45. It should be peripubertal onset to be called atypical menstrual dysfunction because of PCOS. The second important clinical feature which follows chronic anovulation is actually endometrial cancer, and most people are actually not aware of this. The problem here is that in PCOS, the ovulation is not occurring frequently, and therefore the usual monthly progesterone exposure by the uterus after the stage of ovulation doesn't happen. So you end up with what is called an open estrogen window effect. That means there is some follicle maturation going on, multiple follicles are developing, they form a lot of estrogen, but there is no progesterone to oppose it. And if this happens years on years, there is endometrial hyperplasia, and the chances of endometrial cancer risk goes up by almost 3.5 times. That's significant. So one of the important reasons to treat the menstrual irregularity of polycystic ovarian syndrome is not just for that mental satisfaction of having periods regularly, but is also to prevent endometrial proliferation and chances of endometrial cancer. When we say hyperandrogenism, it could mean a variety of things. It could mean hirsutism, by which you mean increased facial or hair on other parts of the body where it is not supposed to be there, like the chin, like the side locks, the upper lips, the chest, the lower abdomen, where women would not have thick male type hair. It could also reflect as acne. It could also reflect as male type alopecia. It could sometimes reflect as change in voice, a deepening of voice because of effects on the vocal cords. Sometimes as increased muscle mass, because androgen can produce a lot of increase in the muscle mass. And of course, if you examine, they could sometimes have clitoral hypertrophy because of the androgen.